Hello, I'm Professor Thompson, and this is your Chapter 11 video lecture on patient assessment. It's going to be a relatively short lecture considering the amount of information. There's going to be several other videos following this lecture on different physical exam techniques for different body systems. Please go through and watch those videos, and you're going to find a lot of good information within those videos. The patient assessment really is one of, if not the most important skill you're going to learn as a paramedic. Okay, your five senses are really your tools for identifying what's wrong with patients, making your differential diagnosis, your field impression, all of that stuff. I commonly said that there is no difference between an early 19th century physician and a paramedic. In fact, a paramedic is actually more equipped and better suited to determine what's wrong with patients. Your physical exam techniques are super important, and improving your assessment skills throughout your career is really important as well. In fact, that's what all the continuing education you're going to do after you become a paramedic, that's what it is for. It is to improve your assessment. Every time you take some certification course, every time you do an in-service, or you're getting CEUs, it's all about improving your assessment because your treatments are already decided. When people say, oh, well, how's this going to change my treatment? Or how is that going to change my treatment? That's kind of silly because nothing's going to change your treatment except for a protocol revision, right? Or a change in your scope of practice. Those things have already been decided. But it's up to you to decide when to utilize those treatments. And your assessment's what gets you there. And the better you are at your assessment, the smarter a paramedic you are, the less clinical errors you're going to make, and all of that. So it really is important that you become good at assessing your patients. And I hate hearing that we don't touch our patients anymore. A lot of people say that paramedics aren't touching their patients anymore. And what they're trying to say is they're not doing good assessment anymore. And it's true in a lot of ways. There's a lot of people out there that aren't performing good assessments. So make sure you don't become one of those paramedics. Your job is to quickly identify your patient's problem, kind of come up with a differential diagnosis, and it's going to be a wide differential initially, right? You're going to, let's say, have a patient complaining of shortness of breath. It could be 20 different things. You're thinking PE, COPD, asthma, emphysema, bronchitis, pneumonia, pulmonary edema, anything, right? Shortness of breath. And then as you perform your assessment, right, and you narrow that differential, you develop a field impression, what you think's wrong with that patient, and you start your care priorities and your treatment. And as you perform your treatments, you've reassessed the patient, see that your treatments work, and you're now developing what they call a working diagnosis. Determining whether your patient is sick or not sick is an intuition that a paramedic develops. There's a gut feeling that goes with this, and there's also your knowledge base, your assessment skills that goes with this. So there's going to be a little bit of both of those things coming into play when you're trying to determine whether your patient's sick or not sick. And you're going to base this on chief complaint, respiration, pulse, mental status, skin color, condition, temperature, that kind of stuff, right? For trauma patients, it might include your mechanism of injury or obvious signs of trauma, your trauma alert criteria stuff. Once you determine the patient's sick, you're going to qualify whether your patient's sick or not sick, and then you want to quantify how sick are they. Is this somebody that I can stay and play, get some control measures in place, or is this somebody I need to load and go and get them to the hospital rather quickly? A lot of times, stable or unstable kind of falls into the very sick or not as sick type categories. Your field impression is kind of what you've determined to be wrong with the patient on scene. Okay, so you got that differential. I told you it's very wide in the beginning, and you narrow that utilizing your assessment skills, and then you develop your field impression, and you start treating your patient based on that. You got to develop a patient assessment style that works for you. Based on sound medical practice. Know a bunch of different assessment techniques. That's why you're going to watch all those videos after this with several different physical exam techniques, a lot of which might not be practical in the pre-hospital environment, but you're going to decide that. You're going to develop different assessments for different patients. And some of those exam techniques that you're going to watch in those videos, they're very specific for the different body systems. So you might have a neurological patient that you're going to perform a lot of those exams on, but you wouldn't perform some, those neurological exams on your patient with chest pain, your cardiovascular patient, they would get a whole different set of physical exam techniques. So go through those videos and really kind of determine what is practical for the pre-hospital arena. Is it a medical or trauma patient? Usually this is kind of cut and dry and it's very easy to determine, but sometimes it's ambiguous. You know, the classic ambiguous call would be an unresponsive patient and an MVA. Did they become unresponsive and then crash their car? Or are they unresponsive because they crashed their car, right? Chicken or the egg? And while that is a frequent occurrence, I guess you could say, it's not that common in the sense of most of the time you're going to know whether your patient's a medical patient or a trauma patient. You respond to a residence for somebody with shortness of breath who's laying in bed, that's a medical patient. It's pretty easy. You respond to a fall victim at a nursing home, that's a trauma patient. So it's usually pretty cut and dry. We're going to reference the National Registry skill sheets a lot throughout your paramedic course. The book it kind of breaks it down a little bit differently. So you'll notice in the scene size up here, it doesn't say consider C-spine precautions, and it includes take standard precautions, where PPE is really right before the scene size up on the skill sheet. So don't get confused. We're following the skill sheet, but this is just the slideshow from your book. All right, so scene size up, this is going to be constantly performed. You're always assuring scene safety, okay? Scene safety is something that doesn't just happen and you verbalize when you get on scene. We know students are the only ones that actually verbalize it. But you're going to assess for scene safety before you get to the scene. Once you get there, you're going to constantly observe and make sure the scene stays safe and be ready for it to become unsafe, because that happens. And up until the point where you leave the scene, you're going to be assuring that the scene stays safe. MVAs are some of the most dangerous scenes that we work. Make sure you're wearing your high visibility vest. Make sure you park your ambulance, you follow the traffic incident management rules, and park your ambulance in front of all the fire engines. Let the fire engines block the traffic for you. All of these things. Use your emergency lights appropriately. Park the ambulance in a way that you can get out of it without stepping into traffic, and constantly stay cognizant and keep a high level of awareness. Utilize extrication gear when needed. There's NFPA standards, there's OSHA standards for high visibility and all of these things, and those regulations are in place to keep you safe. Your safety is your highest priority. Considering a snatch and grab scenario comes into play when you've already arrived on scene and now it becomes unsafe. You've arrived on scene, it becomes unsafe, you have a patient, get them in the ambulance and go. That's the snatch and grab scenario. It's not common. It's not your traditional practice, but it is that gray area of we got to do what's in the best interest of us, and we could do what's in the best interest of the patient at the same time. Hazmat scenes are, of course, classic non-safe scenes. Always consider the possibility for a hazmat when you're responding to a call for several patients, whether it be at an office building or a residence. You know, you have several patients or more than one patient with similar symptoms that can either be a gastrointestinal type complaint where they all have food poisoning from eating the same thing, or it could be a respiratory type complaint, which ends up being, you know, something hazmat. So keep that in mind when responding to any scenario where there's multiple patients. Of course, crime scenes are very dangerous, and you want to make sure law enforcement arrives on the scene before us. This is a very common practice. Formulate an escape plan because scenes can become unsafe. Be aware of violence from bystanders. Patients who abuse methamphetamines can be a large threat as well. Any patient on drugs, really, and drunk patients, you know, ETOH patients, obviously, they pose a threat as well. Environmental risks, definitely, you know, post-hurricane, we saw a lot of environmental risks when responding to calls with flooding, down power lines, you know, traffic signals not in play, people not following, you know, standard traffic laws and all that stuff. It was very high risk for responders. So you have to operate at a high level of awareness on these calls. Mechanism of injury, just remember that's for trauma. There's the forces that cause the damage to the body, and the nature of illness is medical. And that's the general type of illness that they're experiencing. Multiple patients or obese patients may warrant additional resources. Again, you're always considering the need for additional resources, whether it be you need resources for an MCI. Okay, so get that ICS in play if necessary. Get command called, get triage going. If you have multiple patients, get additional resources on the way. Considering the need for law enforcement is an additional resource early on. Hazmat, obese patients, you might need help for the bariatric patient, as far as lifting is concerned. Sometimes you even need a specialized stretcher or a truck for these patients. Standard precautions, another way of saying universal precautions, which is BSI, PPE, the stuff you wear on every call. And that can expand depending on what type of call it is. You would wear eye protection. If you're providing an artificial airway, you should be wearing eye protection on that patient so you don't get stuff in your eyes. Wearing a HEPA or N95 mask. N95 mask if you've got possible TB patient. Wear a gown if you've got to deliver a baby. You're gonna have a lot of body fluids and a big mess there. So make sure you're wearing something to keep you safe from that. And again, PPE, steel-toe boots, helmets, heat-resistant outerwear, your extrication gear, all of that stuff. So after your scene size up, you have your primary survey. First thing in your primary survey you're going to do is formulate your general impression. Your general impression is going to be based on the initial presentation of the patient, chief complaint, their positioning, the age, the sex, all those things. You're going to form a general impression. It could be based on the surroundings, the mechanism of injury, your signs and symptoms, all of those things. It enables you to identify threats to the airway, breathing, circulation, so on and so forth. Avoid tunnel vision. That's important. Always avoid tunnel vision where you think you know what's going on with the patient, so you have this cognitive bias and you just go down this path of the wrong way and totally ignoring something else that might be going on with the patient. That's your tunnel vision. That's really a horrible thing for a clinician because it happens so often, and it's like having blinders, like horses wear. It's like having those blinders on and you only see what it is you're looking for. You're not opening your mind to the other possibilities. Make conscious, objective, and systematic observations. Conscious, objective, and systematic observations. Answer the two questions. Is the patient stable or unstable? Is the patient sick or not sick? If they're stable, might he or she potentially become unstable? If they're sick, how sick are they? Very important questions that a paramedic has to answer relatively quickly, too. So your primary survey, observe level of consciousness. We generally use AFPU to do that. So as you approach the patient, is the patient aware of your presence? That's even before you speak. That lets you know that they're alert, right? If they track you with their eyes as you enter the room, your patient's alert. If you say, hello, what's wrong? And that they weren't responding and now they do, obviously, that's a response to verbal. And then pain stimulus would be a pain response, and then unresponsive if they don't respond to pain. Determine your priorities of care. Identify the age, sex of the patient. Treat life threats as you find them. That's going to be true throughout the entire assessment. As you come across something that's a life threat, you need to treat it. Obviously, if their airway is not patent, you make it patent. If they're not breathing, you help them breathe, so on and so forth. So assess the airway. You're going to utilize the mandible jaw thrust if they have a trauma, right? Head tilt, chin lift for everybody else. And here's going to be the one thing that changes whether you're doing ABCs or CAB is going to be whether they're responsive or not. If they're unresponsive, you're checking a pulse before you do any of this. Okay? And if your patient becomes unresponsive, the first thing you do is check for a pulse. So keep that in mind. All right? When considering airway options, move from simple to complex. Consider the position. Consider spinal injury when deciding this technique. Obstruction requires BLS procedures. If they have some sort of airway obstruction, utilize your BLS procedures, chest pain, if it's a pediatric, back slaps, so on and so forth. The possibility of spinal injury determines how do you open the airway. Again, we talked about the mandible jaw thrust and head tilt chin lift and the difference between the two. Mechanical means requires an airway adjunct. Okay, so whenever you hear mechanical, so mechanical ventilations would be BVM, right? So if you have to provide BVM, you want to then provide an airway adjunct. If patient cannot maintain airway, use more invasive technique. So if the OPA or NPA adjunct does not work, you're going to then move on to a blind insertion airway device or endotracheal intubation. Is the patient breathing? Obviously, that's your first question. If they're not breathing, you breathe for them. A bag valve mask is used to increase rate or depth. So if they ever have a problem with rate or depth and you need to increase those, you're using a BVM. If you're using a BVM, there's a high priority patient. That is a life threat, and you correct it as you find it, right? If they're not breathing, you breathe for them. If they don't have an airway, you provide them an airway. Both of those are life threats. You're going to assess the breathing rate, rhythm, quality, and again, we can increase the rate or depth as needed. Circulation, we can increase the rate there too. If they don't have a pulse, we need to do CPR and AED and all of those things that come with it. And again, that's a life threat. We're fixing as we find it. Major bleeding is a life threat. We fix it as we find it. Okay, and another part of assessing the circulation is going to be assessing the skin, color, condition, and temperature. For the pulse, we want to know the rate, rhythm, quality. Palpate the pulse, get the rate, rhythm, quality. You want to know if it's fast or slow, if we got good quality, good rhythm, if the rhythm's regular, irregular, so on and so forth. And then color, condition, temperature of the skin. There's a lot of different findings that we can get from skin. A lot of times it's the first indication somebody's in shock. Pale, cool, diaphoretic means shock every time, right? Pale, cool, diaphoretic. That person's not circulating to their periphery. They're shutting that peripheral blood flow down to their core. That's a person in shock. That's a sick patient. They're potentially unstable. Okay, so we have a high priority patient. That's a good way to make your transport decision. They could be red or flushed, right, with a fever. That could also be a sick patient. Now, depending on how sick, they could be in septic shock, because they're hot, they have an infection. And it could be a generalized infection, and they could have a low blood pressure because of that. Could be cyanotic, which would also be a sick patient, right? Cyanosis is an indication of hypoxia. Hypoxia is no good. Mottled is a very bad finding. Okay, we would call that a very sick patient as well. If somebody's got that blotched skin, that indicates hypoperfusion, pretty severe shock. That's called mottled skin, and that's a pretty sick patient. Obviously, if their circulation is inadequate, we're going to help fix it, control any bleeding you find, provide CPR if you need to, get the AED out. That's done as you find it, as you find a problem with it. Moving on to disability, ABCD disability. Apu scale and pupils, a quick assessment of neurological deficits. You do GCS for your trauma patients and calculate that GCS. If they have a GCS of less than 12, that's a high priority patient. That, in fact, is a trauma alert. Assessing for gross neurologic defects, you want to have the patient move all their extremities. Assess for motor strength and weakness. Assess grip strength. Assess for loss of sensation. A lot of this is a stroke exam as well. Moving on from A, B, C, D to E, expose, then cover. You're going to expose your patient looking for different physical findings and cover them, especially your trauma patients. Remember the trauma triad of death. Hypothermia leads to acidosis, which leads to coagulopathy, which means they're going to bleed. And you're not going to be able to stop the bleeding. So you want to keep, especially those trauma patients, you want to keep warm and covered. And you want to protect the modesty of everybody else. So keeping them covered is not a bad idea. And you're going to identify their priority and make a transport decision. Sick or not sick, stable, not stable, prioritize that patient. So priority 1 patient in general is going to be your ALS patient that is unstable. A priority 2 patient is going to be an ALS patient that is stable. And your priority 3 patient would be a BLS patient. And they should always be stable. Now, a few things to keep in mind is if you have a priority 1 trauma patient, that's a trauma alert. There's no such thing as a priority 1 trauma patient that isn't a trauma alert. So keep that in mind. And those patients always need to get to the hospital quickly. It's trauma alerts, stroke alerts, STEMI alerts. Those are the patients you want to get to the hospital as quick as possible, providing them whatever stabilization measures you need to get them there. So if you have somebody that's got an obstructed airway, of course you want to fix that before getting them to the hospital because they're not going to survive very long with that kind of thing. So the stay and play is for a critical patient is really to fix things that need to be fixed in order to get them to the hospital quicker. Here are some other examples of your high priority patients. Somebody receiving CPR is a high priority patient, but that doesn't mean that they're a load and go patient. You may be doing the CPR on scene for a while before packaging them, but a post-arrest patient should be transported high priority. Hypoperfusion or shock, of course, that's your go-to, right? Hypoperfusion shock is going to be an unstable or sick patient. Complicated childbirth is a pretty bad patient. Chest pain, systolic blood pressure less than 100. That's an unstable chest pain or unstable angina. That's no good. That's a pretty critical patient. Uncontrolled bleeding, obviously critical. Multiple injuries, poor general impression, unresponsive patients, difficulty breathing. Okay, so hypoxia not corrected, suspected MI with a STEMI. We've already talked about. That's definitely a high priority patient, suspected stroke or a stroke alert. So that's going to be it for the introduction to a patient assessment. Make sure you go through and watch all of those videos on different physical exam techniques. I know there's a lot of different techniques that they do. Not all of them make sense in the pre-hospital environment, but it's up to you to kind of mold your assessment around those techniques and decide which one of those techniques you want to utilize for each patient. So watch those videos, ask questions if you have them. Definitely bring some of those questions to class. And I hope you enjoyed this quick introduction.